So, hello guys for another lecture on hyperthyroidism. Hyperthyroidism is a very commonly discussed topic, and so therefore, without further ado, let's dive right into it. Graves' disease, right? So Graves' disease is an autoimmune disorder that mostly affects young women. Pathophysiology revolves around the thyroid stimulating IgG antibodies, right? So these antibodies, what they do is they bind to the TSH receptors on the thyroid gland, and they begin to overstimulate the thyroid gland, resulting in the excessive synthesis and secretion of thyroid hormones. And since the entire thyroid gland is being affected, unlike in the case of a thyrotoxic adenoma or a multinodular thyrotoxic goiter, the entire thyroid gland is being affected, resulting in a symmetric, diffuse, non-tender enlargement of the thyroid gland with an audible bruit, right? Now, Graves' disease can be identified in a patient with several classic signs that we can see readily in a patient. For example, proptosis, which is the protrusion of the eyeballs. Why does this happen? Because of the edema of the extraocular muscles and the retroorbital fat. Lid lag. Lid lag occurs because of proptosis. Lid retraction also occurs because of proptosis, since the eyes are like bulging, so therefore the eyelids are retracted. So whenever you try to blink, the eyelids, they lag, they don't come forward, they cannot touch one another, and they become retracted, along with pretibial myxedema. So these are the signs. This is, you can see, is proptosis, lid retraction, lid lag, periorbital edema right here. It isn't, easily discernible, but it is there. Periorbital edema is there, in both eyes. Yeah, blurring of vision also occurs, because of extraocular muscle dysfunction. And the patient will also experience pain while moving their eyes because of extraocular dysfunction, muscle dysfunction, right? Double vision, color vision desaturation, Let's move on to the symptoms. Well, since we all, have read the physiology of the thyroid hormones, right? So we know what are their effects on the body, right? On its target tissues. Once the thyroid hormones are released from the thyroid follicular cells into the bloodstream, in the blood there exists a protein known as thyroid binding globulin, and this thyroid binding globulin binds to the T4, right, and carries this T4 to its target tissues, such as the heart, the brain, the eyes, in females, the uterus, right, the GIT, where T4 then undergoes conversion into T3. And T3, which is also known as triiodothyronine, is the active form of the thyroid hormone, right? And it is this T3 that exerts the effects of the thyroid hormone on its target tissues, right? So in case of hyperthyroidism, the effects of the thyroid hormones would be exaggerated, right? Resulting in exophthalmos in the eyes, excessive sweating, enlargement of the diffuse, symmetrical, non-tender enlargement of the thyroid gland. Since the thyroid hormone also acts upon the heart, it will result in arrhythmias and tachycardia, which can be cause of death in some patients. In the GIT, gastrointestinal motility and peristalsis increases, beyond the normal limits, resulting in nausea and diarrhea, occasional vomiting in females, oligomenorrhea, right? Muscle weakness because of the degradation of proteins, hand tremors because of neuromuscular excitability, right? And the patient will also experience, apart from these symptoms mentioned in the slide, insomnia because of neuronal excitability, right? Because of neuronal excitability. Let's move diagnosis. So the investigation of choice for the diagnosis of hyperthyroidism is serum TSH levels, right? Serum TSH levels. The serum TSH levels will be low in patients with hyperthyroidism, regardless of the cause. because we've already discussed that whenever there is excessive secretion of synthesis and secretion of thyroid hormones into the bloodstream, right, this will initiate a negative feedback mechanism upon the hypothalamus and the anterior pituitary, resulting in the decreased secretion of TSH, because the thyroid gland is producing excessive amounts of thyroid hormones, so therefore it no longer needs TSH, right? So serum TSH levels will be low. Other less common tests investigations that we can do include serum T4 levels, which will be elevated, radioactive T3 uptake to differentiate between true and pseudo hyperthyroidism. So we discussed earlier a little bit about the thyroid binding globulin, right? The thyroid binding globulin. Now, in hyperthyroid states, the thyroid binding, all of the sites on the thyroid binding globulin are preoccupied by T4, right? So therefore, the T3 that the patient has taken in, for the purposes of diagnosis, will no longer be taken up by the thyroid binding globulin because the sites are already preoccupied with lots and lots of T3. So therefore this T3 will then bind to the resin that circulates along with the thyroid binding globulin, right? So this basically goes to show that since all of the sites on the thyroid binding globulin are preoccupied, therefore this indicates that the patient definitely is suffering from hyperthyroidism or true hyperthyroidism. If the cause of hyperthyroidism is a thyrotoxic adenoma, then we can conduct a fine needle aspiration biopsy. And a fine needle aspiration biopsy is basically a procedure conducted to examine under a microscope different tissue samples taken from sites wherever there is a lump, or more commonly to examine the breast tissue, the thyroid gland, and palpable neck lymph nodes. This is a visual interpretation of how a fine needle aspiration biopsy procedure is done. We take an ultrasound wand, a needle, right? We then pass ultrasonic waves through the thyroid gland, and the needle, once inserted into the nodule, is then able to collect the tissue sample, right? Treatment. Treatment of hyperthyroidism is both pharmacological, radiation therapy, and surgical treatment as well, right? So the pharmacological treatment for hyperthyroidism includes two medications, propylthiouracil and methimazole, right? Which are both collectively known as thionamides. We can also use beta blockers to reduce arrhythmias, the heart rate and the cardiac output, and also reduce the respiratory rate. So we can also use iodine containing drugs like sodium iodate, right, and iopanoic acid. So the mechanism of action of propylthiouracil and methimazole is that they prevent the conversion of T4 to T3 in peripheral tissues, and they also inhibit the conversion of iodide to iodine by the thyroperoxidase enzyme, right? By inhibiting the thyroperoxidase enzyme. One of the major side effects of these drugs is agranulocytosis. So in patients who are receiving these drugs, they should be monitored. Their leukocyte count, specifically speaking, should be monitored for any agranulocytes, right? Methimazole is not safe for use in pregnancy because of its teratogenic side effects, right? Whereas propylthiouracil is safe for use in pregnancy. In patients who are elderly or who are refractory to antithyroid medication, meaning in patients in whom the antithyroid medication like propylthiouracil and methimazole is not working, or patients with a solitary toxic thyroid nodule, can then be treated by a radioiodine ablation therapy, by the radioiodine 131 isotope. But the thing is, the major drawback of this treatment is that it induces hyperthyroidism. It gradually induces hyperthyroidism. How? Well, it basically results in the destruction of the thyroid follicular cells, right? So obviously it would then result in hyperthyroidism. One thing I forgot to mention about the pharmacological treatment is that these drugs, once started, methimazole or propylthiouracil, once started in a patient, should be discontinued after 1 year after having checked the labs for any thyroid stimulating IgG antibodies, right? Any TSH stimulating IgG antibodies. If the levels of IgG antibodies are low, then we can discontinue, the medical treatment for hyperthyroidism. But if not, then we can continue this medication for another 1 year before tapering it off. And beta blockers should be given along with methimazole when methimazole is being administered to a patient in order to lower the blood pressure and the heart rate. And once methimazole starts to take effect, then the beta blockers should be discontinued within 4 to 8 weeks of use. Then, if radioiodine therapy or pharmacological therapy fails to treat the condition, or if the patient has a very large goiter, right, or plumber disease, which is also known as multinodular toxic goiter, then in that case, surgery can be performed, also known as subtotal thyroidectomy, right? But the risks of this procedure outweigh the benefits. How? Well, as the name indicates, thyroidectomy, the removal of the thyroid gland, or only a part of the thyroid gland. Subtotal thyroidectomy, subtotal meaning only half of the entire thyroid gland is removed in this procedure. So obviously, as you can, well imagine, the removal of only a portion of the thyroid gland or the entire thyroid gland would then result in permanent hypothyroidism and permanent hypoparathyroidism, because the parathyroid glands will also then be removed along with the removal of a portion or the entire thyroid gland, and recurrent hyperthyroidism. So these patients need to be monitored, post-op, and if they, come to your clinic with symptoms of hypothyroidism, then you need to start them on thyroid hormone replacement therapy, right? With levothyroxine, as we've discussed earlier. With levothyroxine, as we have discussed earlier. The last thing that we will be discussing is the thyroid storm. Thyroid storm, as the name indicates, a storm, right? Basically results from an acute exacerbation of the symptoms of hyperthyroidism if the condition is left untreated. Obviously, if you don't address the underlying cause of hyperthyroidism, then of course the symptoms, the effects of the thyroid hormones will then go unchecked, and the hormones will then continue to stimulate its target tissues, resulting in an exacerbation of the symptoms, resulting in thyroid storm. And this condition is characterized not only by the symptoms of hyperthyroidism, but also by an alarmingly high blood pressure, heart rate, respiratory rate, and fever, which should be treated promptly, and the treatment is the same for hyperthyroidism. Thank you so much for your time.